النهارده بسم الله الرحمن الرحيم. النهارده هنتكلم عن روماتيك فيفر. What is acute rheumatic fever? It is an autoimmune consequence. بيحصل infection بالجروب A beta hemolytic streptococcal infection, and then there is an autoimmune consequence with a generalized inflammatory response. وليها كرايتيريا اسمها الموديفايد داكيت جونز كرايتيريا او الجونز كرايتيريا. ده اللي بيخلينا نقدر نعمل الدايجنوسيس. Why is this definitely a group A beta hemolytic streptococcal? لأن 2/3 of patients at least will probably have an acute upper respiratory tract infection prior. For the possibility of these as an evidence of an autoimmune reaction to this type of bacteria is highly probable in these cases. And the peak age is usually below the age of 15, from 5 to 15 or 6 to 15, followed by the seasonal incidence of acute rheumatic fever. And it's very common that it occurs during the change of seasons, زي في الشتاء أو early spring. Usually there is infection with sudden onset of sore throat, fever, headaches, ممكن برضو GIT upset like nausea, vomiting. Then there is signs of infection, especially in the palate or uvula, with small petechiae, and we'll see pictures of this. And of course, with infection, there could be lymph node enlargement. As you can see on the left, there is redness and swelling on both the left and the right, in fact. And on the right, you can see in the upper one, there are small petechiae or small lesions due to the inflammation that is present, or up to little pustules, as you can see on the lower right. And this is also always according to the general condition of the patient who has this infection. There could be a difference of this. But of course, most of these go to the pediatric physician or the ENT. Okay. What are the predisposing factors? Of course, sometimes there's a family history, not a family history in the term of what we can say a congenital or a hereditary disease. We can say because of the same what we can say social environment. So there can be cross infection between brother, sister, and stuff like that. But of course, there are some implications that it could be a genetically determined with some alteration in certain proteins. Like definitely, it's due to the same environment. So cross infection can occur between brother and sister, and so on. So usually in the lower socioeconomic status, because of the poor hygiene associated with the lower socioeconomic status. And again, the age is always in the young age, in the teens, between 15 and 6. The prevalence has changed a lot because of the better education, the better management of sore throat and like that. And it ranges a lot from maybe maximally every 100 children can happen. But of course, it differs also from country to countries. As you can see, in the Western countries, it is very uncommon. But in the sub-Saharan Africa, it is really up to more than 5.7% on average, which is quite high if you look at this census from the WHO that was published in 2005. So it is not so uncommon. And again, it is decreasing in prevalence because of the better hygiene that we see nowadays. As we said, usually it's familial because there is cross-infection between the brothers and sisters, but certain proteins can lead to an increased susceptibility of infection, like in certain M proteins as 1, 5, 6, and 19, and this could help also that. But of course, there occurs a group infection of group A beta hemolytic streptococci in a host, and then there is an autoimmune infection, the autoimmune reaction, and this leads to the acute rheumatic fever and rheumatic heart, rheumatic brain, rheumatic skin disease. Okay. There is no definite way of diagnosis, but Dr. Jones in the mid-40s suggested like criteria to diagnose. Okay. and he put the criteria into two subsets, major and minor criteria. And you need two major criteria, or one major and two minor criteria, to diagnose the possibility of acute rheumatic fever. And the major criteria are commonest. The commonest is the polyarthritis and the carditis, followed by the chorea, and two skin manifestations which are rather very rare. We've seen them very minimal times, which are the erythema marginatum and the subcutaneous nodules. These five are the major criteria. If you have two of them, you have a diagnosis. If you have one of them, you need two minor criteria to have a diagnosis of rheumatic fever. The minor manifestations or criteria could include fever or arthralgia with an increased ESR, increased inflammatory process with a CRP, prolonged PR interval, which is pathognomonic of infection of the endocardium, thus prolongation of the PR interval. And also, what we see a lot and what is important, any evidence that this is a group A beta hemolytic streptococcal infection, whether it's a throat swab, an ASOT, or a positive culture. Okay? So here again we agree that there should be two major criteria, or one major and two minor, to diagnose a case of rheumatic fever. Okay? What are the major manifestations? This is the most common. This is the most we've seen. I don't know if you've seen a lot of cases of acute rheumatic fever in the acute stage, but this is the most common, occurring in nearly 3/4 of patients. Usually it involves larger joints. It is usually not symmetrical. You don't find both knees at the same time. You can find it one knee at a time and later on a knee. And that's why they call it migratory or fleeting. Fleeting in the sense that it runs away. So it's asymmetrical, usually large joints. You definitely, in most cases, you don't find both same joints inflamed at the same time. And there is redness, hotness. It's inflammation, red, hot, and tender. It's not just a pain. It's not arthralgia. It's an inflammation. It's arthritis. Okay? But of course, pain can precede the inflammatory process. Migratory, that I mean, it does not. It could go from the right knee to the left shoulder, to the right hip, to the left ankle, usually affecting the big knees. And there is an incredible response when you give these patients acetyl salicylic acid. They respond very quickly, and this is again a positive thing. It's not like infective arthritis, which responds to antibiotics mainly. Here it is very responsive when you give aspirin, طبعا in high doses, not in small doses, and we will discuss the data. And also something is good, because this is an autoimmune infection. It's not a lot of pus. There's no pus. There's no inflammatory process, including a lot of bacteria. So the deformation of the joint is usually not there. You find the joint is really inflamed, then it goes back to near normal without any deformities. And this is the earliest manifestation and the commonest. Okay? And usually it does not accompany chorea. That's like rahma min Rabbina subhanahu wa ta'ala, because a chorea, which is an abnormal movement of the arms and legs, if you have inflammation of the joint, it would be extremely painful for that. فَمِن رَحْمَةِ رَبِّنَا, this usually doesn't occur. And it can occur, of course, with carditis. And what has been observed, we don't have an explanation. لكن لما يكون في severe arthritis, the affection of the heart is usually a little bit mild. And sometimes when you have an incredible infection of the heart, myocarditis, endocarditis, usually the polyarthritis is not so severe. Okay? But this is an observation, not related to any explanation. Okay? The carditis is the one we see sometimes. It occurs nearly in half of patients. It's not so common nowadays. It resembles any myocarditis, actually, and we will see what differential diagnosis we can see. And it affects all layers of the myocardium, the pericardium and the endocardium. So it is a pancarditis, and you find, of course, tachycardia out of proportion to fever. You might find a mild grade fever and extreme tachycardia, and we will just for a second. Sorry for the interruption. It's a pancarditis, okay? So it can affect the endocardium, causing valvular problems, prolongation of the PR interval, myocarditis, which is inflammation. You find ST segment changes, tachycardia. The patient is quite in a grave condition, and in very few cases, we don't see this a lot, you might be in acute heart failure. Pericarditis is just like any pericarditis with a pericardial rub and stuff like that. Okay, the commonest valve affected when we have endocarditis is the mitral, followed by the aortic. Okay, and it can occur as a mitral regurgitation, aortic regurgitation, or a mitral stenosis, and less commonly aortic stenosis. Okay, and the valvular affection, especially the stenosis, takes a long time. It doesn't occur immediately, not like the regurgitation. A regurgitation can occur with myocarditis even because of the inflammation itself, dilatation of the left ventricle, thus mitral regurgitation, and this might regress. But affection of the endocardium causing mitral stenosis بياخد وقت طويل شوية. يعني usually you find the patient at the age of 15 with recurrent tonsillitis. Sometimes they have arthritis, and then years and years later in the history taking, they might start to complain of pulmonary venous congestion symptoms, which could be due to mitral stenosis in a lot of cases. Okay, of course you can see a lot in the echocardiogram. Of course, a myocarditis, you might see an increase in the left ventricle dimensions with a poor function, endocarditis or valvular deformation we can see, and thus any valvular lesion like stenosis or regurgitation, and pericardial effusion or pericarditis can occur. So it is a pancarditis, and these are like pictures. As you can see on the upper left, this is thickening of the mitral valves in the parasternal view, and one of the what we can say hallmarks when you look in an echo and say this is probably of rheumatic origin is restriction of motion of the posterior leaflet. You can have thickening of the valves due to many causes, but one of the quite hallmarks when in echocardiogram you do it, you find restriction of motion of the posterior leaflet. تبقاش بتتحرك زي الباقي، فتقول ده probably rheumatic thickening. Probably, we cannot be sure. We didn't take a biopsy. We take it by history and other things. Okay, the chorea, which is like involuntary movements of the arms and legs. It's like somebody is trying to dance, and they called it Sam Vitus's dance. That's what its old name was. Okay, it doesn't occur a lot. It occurs maybe in 10% of cases, maybe even asymptomatic, so we don't know if it's occurring or not. But usually it's more in girls than in boys, and it is rather a neuropsychiatric disorder, if we call it like that. And of course there are psychiatric problems. That's why it's neuropsych. It's not just abnormal movements. There could be emotional liability, hyperactivity, and sometimes obsessions. That's why sometimes you can't, if you want to remember, it occurs a little bit more in girls, which are a little bit more emotional. No offense or intended. Okay. And there are elevated titers of anti-neuronal antibodies against areas in the basal ganglion. This is where this really occurs in most cases and occurs. And what are the clinical, what we call examination or maneuvers? We can see this. We can see irregular contractions of the muscles of the hands. When you put your fingers into her hand or his hand, there is irregular contractions like a milking of any cow or sheep. This is called the milkmaid's grip. She's trying or he's trying to milk. There is spooning or pronation, spooning of the hands when they're extended, and wormian movements of the arms and the tongue, like a worm or a snake. Okay, and this is a picture of what a patient would look if he's moving like a dance in the chorea. Okay, the erythema marginatum, very uncommon. I've seen only 2 cases actually. It's extremely rare. It's more rarer than we see. The arthritis is number one as in commonest in occurrence, followed by the carditis, followed by the chorea, and the skin manifestations are quite rare. This occurs less than 3%, I think maybe even less, because I've seen it only once or twice. What is it? Is it erythematous? Erythema is reddish with an evanescent, is a pale center, as you can see in the picture. Serpentinous, which means it looks like a snake. It looks not just a single patches together that look like a worm or a snake, mainly on the trunk and extremities, and can increase when you warm the skin. Okay, they're usually evanescent. That means they go very quickly. A subcutaneous nodule is probably the rarest, because it can go into differential diagnosis with so many things. It usually occurs on the extensor surfaces, and it could resemble, as you can see here near the elbow, it could a lipoma, a xanthoma. So you can never be sure, is it really probably due to a subcutaneous nodule due to rheumatic affection or due to something else. So it is quite uncommon, usually on the extensor surfaces, and the differential diagnosis is so severe you'll probably miss it if you ever see it. The minor manifestations is not arthritis, arthralgia, just pain in the joints, not the redness, swelling as we talked about before. Fever is minor because I know it's called acute rheumatic fever, but fever can occur due to many things. So this is not a major criterion. It helps in the diagnosis, but it's not as important to be put as a major criterion. Acute phase reactants like the ESR, the C-reactive protein, leukocytosis, and on ECG in carditis, you might find a prolonged PR interval because of the endocarditis that is present. Okay? So how to diagnose? First of all, we said this is an autoimmune reaction to the group A beta hemolytic streptococcus. So the first things first is probably if there is an infection. The infection of a group A beta hemolytic streptococcus, and this can be seen لو خدنا throat culture, and we see a positive throat culture for these organisms. Okay, and if we don't have that, we can do an antistreptolysin O titr. And I know it's elevated in a lot of patients without rheumatic fever, but if you have a very high in children or high in adults, this could be helpful. It is one of the criteria of diagnosis. It is not something to say we don't have or we have, because we can have a normal antistreptolysin O titr and a problem with rheumatic fever, or we can have a high antistreptolysin titr and there is no rheumatic fever. Okay, doesn't mean, it means just that we have infection by these kind of organisms. Okay, and sometimes people do an anti-DNA B titr to these organisms. Again, very uncommon. We usually don't do this. If you want to make more sure, you can do something called a streptozyme or a slide agglutination test, okay, to detect antibodies against the M antigens that we just talked about. It's less standardized and nobody really uses it a lot right now. Okay, so this is the first part. Second part, we have an infection and then an autoimmune reaction. The autoimmune reaction can affect the heart, causing carditis, can affect the joints, causing arthritis, the brain, causing chorea, or the skin, causing erythema marginatum and subcutaneous nodules. And these are some of the different differential diagnoses. Of course, rheumatic arthritis can be differentially diagnosed different from rheumatoid. In rheumatoid, it's more affection of the smaller joints, usually symmetrical, not fleeting or polyarthritis. Okay, this is common. Carditis, it will go with any carditis. You can never be sure 100% if this is carditis due to rheumatic fever, due to viral, unless you, of course, you have viral testing or you have a biopsy, or of course by history that this patient had an acute sore throat and followed later on with these manifestations. A chorea, there's multiple things like the Huntington's chorea and the Wilson's disease, a problem with copper. And this is a problem that sometimes you can never be sure what to do. How about treatment? Of course, in the acute phase, if it's the sore throat or the acute rheumatic fever, rest, number one. If you have an infection which is present, you give antibiotic therapy. Of course, we're going to discuss primary and secondary prevention too, and this is an important thing, and it was just asked as a question in the last examination, okay? So it depends. Usually it's a penicillin, or if you're penicillin allergic, it could be erythromycin. This is the thing is. Anti-inflammatory medications here are extremely important when you have arthritis, carditis, and here if you take, for example, arthritis, the dose is heroic. We're talking about 75 to 100 milligrams of acetyl salicylic acid per kilogram per day. So if we have like a 50 kilogram boy or girl or even adult, we're talking about 5 grams of aspirin, which is a huge amount. And usually we give a lot of antacids and proton pump inhibitors because this is very irritant to the stomach, but this is the actual dose of anti-inflammation, okay? We divide the dose, of course, into 4 doses at least, so not to load the stomach with a lot of aspirin at a single point in time. And we give it for a prolonged period. It's not a couple of days or weeks, it's 4 to 8 weeks. So you can imagine how much burden the stomach is really carrying on. If there is carditis and there is non-response to aspirin, a lot of the times we give corticosteroids, or corticosteroids are the hallmark. Sometimes they respond to aspirin or acetyl salicylic acid, but here we give prednisolone and 2 milligrams per kg per day, again for 2 to 6 weeks, okay? Then we down titrate, because corticosteroids should be down titrated and removed a little by little from the body, so we can have to avoid a relapse. Of course, supportive measures for anybody with a carditis. Of course, fluid restriction or diuretics. If there's edema in the body, you can give, if there's an increased heart rate, beta blockers, digoxin and stuff, okay? In the chorea, usually it doesn't occur on the acute phase, and here it's an abnormal movement, as we discussed, so it's neuropsychiatric problems. So part of the treatment is giving sedatives like phenobarbital, okay, or haloperidol or chlorpromazine, and these are the doses if you want to take a look at them, of course. So what about prevention? And this is the main thing that has reduced rheumatic fever, is the prevention. There's the primary prevention, that is to say, when I get a group A beta hemolytic streptococcus, when I get a sore throat, I treat it really good, okay? So I don't have any reaction to this. A secondary prevention is I've started problem with rheumatic fever and I'm avoiding relapse of this rheumatic fever again. So this is really important. Who should relieve prophylaxis? Of course, primary prevention, anybody with a sore throat. We treat them with antibiotics like penicillin or erythromycin for 7 to 10 days as recommended, okay? Secondary prevention, this is important because we have a lot of, like what we say, ideas. And do we give it for 5 years? Do we give it till the age of 21? Do we give it for 10 years? Actually, without carditis, it's 5 years. And 5 years is why 21 years was suggested, because usually it occurs at the age of 6 to 15. So at 5 to 15, you get the age of 20, so 21, and that's it. That's what 21 years has came from, okay? But you have carditis, and carditis is a little bit more significant as an inflammation. You might extend the 5 to 10 years of benzathine penicillin, the intramuscular penicillin, and we'll talk about the dose. But if you have carditis and, let's say, significant mitral stenosis, significant affection of the aortic valve, then you can even extra 10 years from the last episode, or extend it up to the age of 40. There is no data to support using it for life, but there is no data to say that it's harmful if we take it for life. Okay, this is an area which has not been infiltrated. If you have a patient who's at 40, the probability of relapse of rheumatic fever is low. So you can stop at this age probably. But if you have a patient who has recurrent sore throats, even at the age of 40, sometimes I would say take the penicillin for life, okay? The doses we know in the adults is 1.2 million units, taken intramuscular every, I know there's a 2 to 4 weeks, but it's usually 3 to 4 weeks, okay? Usually it is best at 3 weeks, so the effect does not go or tailor down a lot, but it is more convenient for the patient to remember every single month, like the first week on every month, January, February, and that. And if you have a patient who's below 27 kilograms, or here, of course, it's not 40 like the other medications, we tailor down the dose to 600,000, half the dose, okay? Every 3 to 4 weeks. If you have a problem with the intramuscular, and every single time the patient takes an intramuscular one, he should have a test for allergy, because there could be a reaction. And patients who did not have an allergy can get an allergy later on, and patients without an allergy can get an allergy, and patients with an allergy later on might have this allergy removed, okay? Of course, you can give also oral penicillin, but this is not every 3 weeks, it's daily, which is rather bothering, okay? Or if you have other problems, you can give sulfadiazine, okay, or macrolides. So this is the part on rheumatic fever, and I will stop here for any discussion should you want. Okay, and now we're going to discuss a more commoner thing that we see a lot now. We've seen a lot before, and now we still see a lot, which is the infection of the endocardium or infective endocarditis. We'll take a look at what is the definition, what are the symptoms, how to diagnose, which is very important, how to treat, and what are the complications, because sometimes complications compel us to do something else. Rather than antibiotics only, we might do surgical interventions. How to prophylax against this, because sometimes patients are prone, okay? And we'll take a whole summary later on. What is infective endocarditis? Infective is infection, endocardium, infection of the endocardium. So it's an inflammatory process inside the endocardium. This is not an autoimmune reaction. This is infection due to an organism, be it a virus, be it a protozoa, be it a bacteria. This is not like rheumatic fever, which is an autoimmune affection to streptococcal infection. This is actual, the organism itself has invaded and caused inflammation in this part of the heart. What to define, there were so many definitions, but one, you can have left-sided or right-sided anatomically, okay? You can have device related, like a pacemaker lead or an ICD lead. And what has been updated years and years ago was the timing of the prosthetic valves. You can have it on a native valve or a prosthetic valve. The prosthetic valve was divided into several subsets, but now it's either early, before 1 year, or within 1 year after the surgery, or later, which is 1 year or above. Simpler. Used to have 3 subsets, now it's 2. So you can have it on the left side of the heart, right side of the heart, related not even to the heart like a lead of a pacemaker or an ICD or CRT. And if you have it in the heart, it could be due to a native valve or a prosthetic valve. You can have this also related to where the infection has been acquired in the community, like you get infections for everybody, or in hospital. Sometimes patients are admitted due to another cause, and inside the hospital, IV lines or infection, they can have nosocomial infection. Or of course, what we've seen a lot now in right-sided endocarditis is usage of intravenous drug abuse, especially if they use repeated usage of syringes between different people. Okay? What is its prevalence? It's not so prevalent, but In the Western countries where they have more data than here, it usually occurs a little bit in the older age because of the decreased immunity. We have another problem. We have a little bit more rheumatic fever, and sometimes intravenous. The commonest pathogen was streptococcal infection in the developed countries, but in the developed they have more the Staph aureus. يعني احنا عارفين streptococcal viridans. It's still the commonest in our country, in our region, yes. But in the more developed countries where they have more data, it's more the Staph aureus. And what has been introduced as a way to manage is something called the reference center. يعني ايه reference center؟ يعني حالة الانفكتيف endocarditis دي should be treated in a multidisciplinary area. Sometimes they might call it an endocarditis team. Okay? It does not include a cardiologist فقط. It could include imaging specialist, cardiac surgeon because of complications. An important, very important part is the microbiologist. Very important. Because they know how to do cultures correctly and they can look for different organisms, Sometimes if you have a difficult case or a complicated case, don't treat in a small hospital. You have to take them to a hospital where there is a team constituting of these subspecialties, because anytime we might require any of these specialities to help us. So what are the symptoms? Of course, it's an infection. So usually there's fever in most cases, okay? Sometimes there's a new intracardiac murmur, okay, because of rupture of the papillary, dilatation of the alveolar annulus, or an immune reaction. And this is the classic triad. Infection, which is fever, night sweats, you might see infection or an increase in body aches like arthralgia or myalgia, anemia, weight loss. This is all hallmarks of infection. A cardiac disorder like a murmur or heart failure, acute onset heart failure, again, one of the cases that we see a lot sometimes when we have infective endocarditis. And embolism. If this infection has migrated anywhere, we can have loss of pulse anywhere, in the arms, legs, or in the brain with a stroke, okay? A myocardial infarction, I've seen it once, and sometimes, of course, when we go to the kidneys, we can find hematuria, and this I've seen, okay? And of course, there's always the immunological signs of embolism like the Osler nodules and Janeway patches and splinter hemorrhages. So when to suspect? Because infective endocarditis goes under a title, infection or fever of unknown etiology. You get a patient with fever and you don't know. This could be infective endocarditis, it could be familiar Mediterranean fever, it could be so many things. This entity of fever of unknown etiology, infective endocarditis, is always a differential diagnosis that you should see. But if you have fever and you have a history of this patient having previous infective endocarditis, you might think of it. He recently had a pacemaker, an ICD, this might be. A fever and the patient was fine, and with the fever he started to complain of heart failure symptoms. Again, if you have blood cultures suggestive of the commonest organisms, we said streptococcal viridans in our communities, staphylococcus is more common now in the Western countries. So this is where you suspect. Then we look at how to diagnose, because the diagnosis here is the Duke criteria. Remember, there was the Duckett-Jones in the rheumatic fever, and here is the Duke criteria. Again, we have major and minor. We need 2 major, or 1 major and 3 minor, or 5 minor criteria to diagnose. The major is simple. It's either I see the organism. I see the organism, it's either in a blood culture or I see it inside the myocardium. And there are criteria to diagnose what is this, an infection, i.e. this is an organism, or a thrombus. There are differential diagnoses because it's a mass, but usually it's more mobile, it's attached with small, it's pedunculated, not sessile, multiple usually. So this is it. So the major criteria is I see an organism, whether in the blood culture or in the myocardium or in the heart, sorry. Minor criteria, again, like rheumatic fever, and usually it's low grade. Very uncommon to have a very high fever in infective endocarditis. If I have history of intravenous drug abuse, this is a minor criterion because we see this quite a lot right now, okay? I don't know, they have money to buy the drugs, but they don't have money, which is a couple of pounds, to get a new syringe. I find this really, really funny. Vascular phenomena, immunological phenomena like the ocular nodules, Roth spots, and Janeway patches, or microbiological cultures that are not so common with the common organisms, and we'll discuss this. So here is from the guidelines. When you talk about a definite infective endocarditis, microorganisms demonstrated by culture or histological examination, okay, or pathological lesions like a vegetation or an abscess, and they have to be 2 major or 1 major and 3 minor or 5 minor. A possible infective endocarditis is 1 major and 1 minor or 3 minor, because when you have a possible infective endocarditis, you will investigate the patient a little bit more. Not to say go home, you don't have anything. But a rejected infective endocarditis is one of these. If I have a definite other diagnosis, that's number 1. If I have resolution of symptoms within a couple of days or 4 days or below, this is not infective endocarditis. Or there is no pathological evidence at surgery or autopsy, and does not meet any of the above criteria in the number of major or minor criteria. So sometimes, yes, fever of unknown etiology can be infective endocarditis and can be other causes, okay? And this is just, I'm not going to go through it in details, but it shows us what are the typical microorganisms. And that's why when I said in minor criteria, you can have atypical organisms or not so common organisms, and this is minor. On the other hand, you can have a blood culture which is positive for more commoner criteria as a major criterion. We're talking about Streptococcus bovis, the Haysick group, or the Staph aureus. These are the common organisms, or community acquired enterococci. These are the common organisms. If you have organisms other than that, probably they go as a minor criterion, not as a major, okay? Staph and Strep, remember always. The blood cultures, 2 or 3, there's a little bit of a debate. Do we take 2 or 3? We still, as per protocol in our institute, we try to take 3 from different venous sites, and we make sure that each site is well cleaned before we take because we can have some organisms on top of the skin, okay? So this is really important, and we always look for aerobes, anaerobes, and fungal infections. Not always do we look for fungal infections unless we suspect like huge vegetations in the heart, or if a patient is quite immunosuppressed. Okay, this is it. So is it 2 or 3 samples? Again, a lot of places take 2, a lot of places take 3. As per protocol, we still use the 3 samples. On echocardiogram, we said blood cultures, and we look for organisms like the staph, strep, enterococci, okay, and staph bovis. Here on echocardiogram, if you do a transthoracic echo and you don't find anything, this doesn't mean we don't have infective endocarditis. A TE, as you can see, as you will see right now, in the newer guidelines, or the newest, guidelines, is extremely important. And sometimes TE can be repeated just to check if the patient does or does not have infective endocarditis. يعني لو أنا عملت transthoracic echo, there's no evidence of vegetation, abscess or anything, مش معناه إن this is خلاص rejected. I might do a TE. And sometimes I might repeat the TE to check, because TE also has a better sensitivity and specificity when you're looking at posterior valves like the mitral. You're not going to really see it so good as by the transthoracic, okay? And you look at the data, the sensitivity of the transthoracic is low. It's around 50%, 40 to 63, while the TE is up to 90s, okay? And this is, look on the right side, this is what you're looking for. If you have a transthoracic echo, it's going to be either positive or negative. If it's positive, you also do a TE to check, okay? But if it's negative, and this is what we're talking about, sometimes it's negative. If the patient has a high likelihood of infective endocarditis, do a TE. If has a very low incidence, and these are very few patients, here you can stop. And if the TE in any case is negative, you might repeat it a week to 10 days later. يعني TE أهميته هنا is extremely important, because sometimes the vegetations are too small, because sometimes the vegetations have migrated and embolized, so we might not see them in the heart, but they were there and they might come again. Okay, so if you have a transthoracic echo which is positive or negative, most of the cases you're going to do a TE. The only case you will not going to do a TE if the patient has a negative transthoracic echo and a low likelihood of infective endocarditis. And sometimes you do a TE and you repeat it again within a week to 10 days. And what are we looking for? Vegetations, highly mobile, pedunculated, usually multiple masses seen on the valves usually. Okay, but of course you can see them sometimes on the septum. Well, again, not a very common, a very pathognomonic echocardiographic feature of infective endocarditis is an abscess, especially an aortic root abscess. And here again, transesophageal echo can see it very well. Of course, in prostatic valves, you might see infection of the sutures, and you see a dehiscence of the prostatic valve. These are common to be seen. Okay, and these are the guidelines. A transthoracic echo is a class 1. A transesophageal echo is class 1 in all cases nearly, okay? And a repeat transesophageal, if you see in the fourth row, within 5 to 7 days, in case of initially negative examination when there is clinical suspicion of infective endocarditis. So a repeat in the transesophageal echo is there. That's important. These are definitions of what they should look like: vegetations, abscesses, and this you can find in the guidelines and present in the slides. I'm not going to go just repeat them, okay? So we said a definite is 2 major or 1 major and 3 minor or 5 minor criteria of the Dukes. A possible is 1 major, 1 minor, or 3 minor. A rejected if I have another diagnosis or it does not follow any of the above rules, okay? So this is important. So treatment basics, and this is important. So we agreed, we have to diagnose it because it can go into a differential diagnosis with so many different entities, and the major criteria is seeing the organism, whether by blood culture or by echocardiography, be it transthoracic or transesophageal. So now you have a case which is infective endocarditis. How to treat? It's antibacterial. Rheumatic fever, remember, is autoimmune, so it's anti-inflammatory. This is a totally different thing, okay? So we take bactericidal, of course, if it's bacteria. And the drug choice is according to the pathogen, okay? It takes a little bit more longer than a sore throat. It doesn't take a couple of days, it doesn't take a week, it takes up to 6 to 8 weeks in certain cases, okay? And of course, in prostatic valve endocarditis, it might extend even longer, okay? The most common are the amoxicillin and gentamicin, the penicillin and the gentamicin. Of course, if you have beta-lactam allergy, it's vancomycin. So let's take a look at the standard 4-week treatment. A standard 4-week treatment. We take penicillin G or amoxicillin of ceftriaxone. The penicillin G is the commonest that we use still. We use up to 18 million, maybe a little bit more, in 4 to 6 divided doses, because this is the duration of action of penicillin for 4 weeks. And we can have an extra dose of gentamicin or nitilamycin. We don't have nitilamycin, we use gentamicin. Instead of 3 times per day as we used to give, it's now once per day, a single dose per day, okay? 3 milligrams per kg per day, once in one dose for 2 weeks. Why 2 weeks? Because of their ototoxicity and nephrotoxicity. Don't extend this, okay? So this is important, that gentamicin shouldn't be given for long. So we can have the 4-week duration and the standard 2-week duration. If you have strains or let's go for beta-lactam allergic patients, is the vancomycin, okay? 30 milligrams per kg, okay? I know it's not so easy to revise all of these, and still we're going to look into different bacteria, okay? If you have strains which are resistant to penicillin, and here why a microbiologist is important part of our team, because if it's not a competent microbiologist, you will give antibiotics empirically and the patient is not going to improve. And if he doesn't give you the resistance to antibiotics and the sensitivity to other antibiotics, you will not get rid of this bacteria, okay? So here you can give a penicillin G with gentamicin, or beta-lactam allergy, it's vancomycin plus gentamicin. So it's penicillin, gentamicin, vancomycin. 3 medications till now, right? 3. But here is one of the biggest problems. Sometimes you get a blood culture which is negative, and you're sure that the patient is probably infective endocarditis. Sometimes you get atypical organisms like the Brucella, the Coxiella burnetii, Bartonella, Legionella, Mycoplasma. Of course, again, if you have a good microbiologist, he will look for these atypical organisms. And you know, culture negative endocarditis is an entity which is really a little bit difficult. But take a look with me. I'm going to show you. It's doxycycline, and levofloxacin in Legionella mycoplasma. Okay? So we add 2 more antibiotics. Because if we're going to add too much, of course, we're all walking around with notes in our hands or our guidelines in our pockets now with the in our smartphones, so we can get it. But if you want to remember easily, it's doxycycline for anything except Legionella and Mycoplasma. It's levofloxacin, okay? Because I know you look at this, oh my God, there's so many antibiotics. Actually, there are not too much, but there are several doses and several durations of action. How about if you have an acute, severely ill patient? Again, you can use ampicillin with flucloxacillin or cloxacillin, or sometimes in early prostatic valve endocarditis, they add now rifampin, okay, the anti-tuberculous medication, okay? But this is part, you're trying to get rid of an organism. Sometimes you get complications. And here, sometimes just eradication with antibiotics is not enough. So you have 3 actually indications for surgery. Is it there is any heart failure? Is the organism not responding to the antibiotics or uncontrolled infection? Or there is recurrence or prevention of embolism? So simply, if you have heart failure with severe acute regurgitation, say of the aortic valve, mitral valve, you're going to help the patient with the antibiotics, but the patient will never be better without aortic valve replacement or mitral valve repair. This is important, especially if the patient has refractory pulmonary edema or cardiogenic shock. If the patient is not in refractory pulmonary edema or cardiogenic shock, you can do this in a less emergency situation, okay? How about uncontrolled infection? If the patient is not responding, if the patient has an infection of fungus, and this fungus is usually big, it does not respond so simply to antifungal medications. If the patient is having still positive cultures on follow-up, this might also lead us to get this valve and the vegetations out of the body, okay? Prevention of embolism. This is a very important thing too. Which do you think will embolize more? A large vegetation or a small vegetation? A larger one. A larger one will cause more harm. Let's put it this way. Yes? And this is the indication on the size. Of course, small vegetations can go, but the probability they will occlude a big vessel is minimal in comparison to a big one. I understand what you think. Of course, a small one might easily go, but it will probably do nothing. So if you have left-sided embolus, left-sided vegetations like in aortic or mitral, which is more than 10 millimeters, and there are embolic embolisms that happened before, this is an indication of surgery. Okay, so it not only 10 millimeters, but with a history of previous embolism. If you have the same aortic or mitral with vegetations of 10 millimeters, but there is severe stenosis or regurgitation, and the patient is not in such a bad condition, you might consider it. It's a class 2A. Okay? If you have a very large vegetation, more than 30 millimeters on a left-sided aortic or mitral, you can go ahead. Even if the patient is stable, even if the patient hasn't had an embolic manifestation, you can go ahead and do surgery, because the possibility that this will embolize is not only high, but also it can affect large arteries in the body. Understand what I'm saying? Yeah? Okay. This is important. On the right side, it's if again microorganisms difficult to eradicate, tricuspid vegetation is not 30, not 10. It's in between 20 millimeters with recurrent emboli. Okay, with recurrent pulmonary emboli, because the tricuspid valve will embolize into the pulmonary tree. It will not embolize systemically. So, what are the complications? Of course, heart failure. And this is a little bit, we see it sometimes in prostatic valve endocarditis, when there is dehiscence of valves and severe or acute regurgitations, whether it's aortic or mitral. And this is not, this is the commonest indication for surgery, actually. Infection is not improving, and we said if there's no uncontrolled infection, sometimes we can do a surgical procedure to remove the valve and the vegetations. Embolism, as we've seen, very common, myocardic aneurysms in the brain. You can have that in the spleen. You can have it anywhere in the body. Of course, on the right side, it's going to go to the pulmonary tree. And of course, you can have all of these complications, as you can see. Who are the patients that you should really take care of? We should take care of everybody, but who are the patients with the poorer outcomes? Of course, as we grow older, immunity is less. Prostatic valve endocarditis is worse than native valves. Of course, if you have any comorbidities like frailty or immunosuppression, or if you're diabetic, these are the patients that you should take care, are higher risk for complications and outcomes after the infection is bad. So what about prophylaxis? I know we give antibiotics, as you were just discussing, we give a lot of antibiotics anyway. And there is an abuse sometimes in antibiotics, but actually here the most important I want to stress upon is importantly any oral procedure we should take care, because in the mouth we have a lot of bacteria, especially if there is any manipulation of the gums. If there's just teeth cleaning, you don't have to give, okay? If it's cardiac catheterization, believe it or not, we shouldn't give, but we sometimes give just to make sure we're protecting our patients. And again, there's no data to support this a lot. But of course, in high-risk groups, you might give them for the simplest of reasons, like in prostatic valve, a history of previous infective endocarditis, a congenital heart disease, especially cyanotic without correction, okay? This, sometimes we use penicillins prior to the intervention, okay? So dental procedure, especially, as you can see, manipulation of the gingival or periapical region of the gums, okay? This is important. It's not recommended like treatment of superficial caries, removal of sutures, dental x-ray. We sometimes use a lot, which is not important. And of course we use a 2 gram of ampicillin or amoxicillin as we use, okay? Or if we have allergy, clindamycin. And these are the 2 most antibiotics used even by dentists when there's an infection in the mouth or the teeth, okay? So again, this is reiterating why we said we should take care that those at highest risk are those with a prostatic valve, patients with a previous infective endocarditis, patients with a congenital heart disease with a cyanotic not corrected, or any cyanotic, or any congenital repaired with a prostatic material. So in summary, I know there's a lot of data, but I tried to simplify it. It's rare, but a high mortality if left. It's an infection of the valves. It's an infection of the endocardium. It can occur also in the different chambers. It's a differential diagnosis of fever of unknown etiology. You have to see the organisms when you're talking about, and the major criteria of seeing the organisms is either by blood culture or by echocardiogram. And TE, as we said, can be repeated once or twice to make sure or to rule out an infection. Minor criteria are so many, but when we have a clinical suspicion, we can start with penicillins. We can add gentamicin if we want in certain cases, but it's in one dose for 2 weeks. No more gentamicin for a prolonged period of time for fear of nephrotoxicity and ototoxicity. Okay? And sometimes we need surgery when the infection is uncontrolled, when there is a complication of heart failure, or if there is high predilection, or even there was a previous embolism. And prophylaxis is important, especially in dental procedures at those at high stress. Again, not in all surgeries do we need prophylaxis. Like in cardiac catheterization, we shouldn't be so scared, but sometimes we give it without any really big evidence, but we might feel safer. And thank you about that.